It is an enormous privilege to introduce you all to Dr. Rebecca Etz. Dr. Etz is a professor in the Department of Family Medicine and Population Health at Virginia Commonwealth University and co-director, along with Dr. Kurt Stange, former editor of the Annals of Family Medicine, of the Larry A. Green Center, whose mission is to reclaim and reconstitute the intellectual foundations of primary care. Dr. Etz received her PhD in anthropology and postdoc in health services research from Rutgers Robert Wood Johnson Medical School. Dr. Etz is a well-known qualitative researcher and thought leader, and most recently helped co-author the critical 2021 National Academy of Medicine Consensus Report on Implementing High-Quality Primary Care. Many of us know Dr. Etz as the researcher who sent us monthly installations of the quick COVID-19 primary care clinician survey that has been used to gather and elevate voices of primary care clinicians around the nation throughout the pandemic since March of 2020 to inform policymakers during this tumultuous time for both our practices and our patients. As one deeply interested in patient-doctor relationships, I've been a longtime fan of Dr. Etz's work. I am particularly moved by her deep appreciation for trying to center value in what is the essence of primary care as bound in trusting relationships that transcend transactional values such as a hemoglobin A1C or blood pressure measurement. Today, she will share with us the development, testing, and application of the person-centered primary care measure, or PCP-CM, that has been endorsed by the Centers for Medicare and Medicaid Services and the National Quality Forum. Dr. Etz, a warm welcome to the University of Wisconsin Department of Family Medicine and Community Health, and hopefully someday we will do this in person in Madison.
I'm hoping for that too. Thank you. Thank you, everyone. That was a very warm welcome. And I should have recorded it for my mother because she wouldn't believe that people say such nice things about me. Thank you, Jen. That was great. So I have here a presentation for you on the measure, and it is kind of, anthropology style. So I've got a little story, some pictures, stuff to do. For anybody who's out there who has taken our COVID-19 survey, I just want to send you out a quick thanks. We did announce that we were wrapping that survey up as of survey 36, which was the last one. We had so many people write to us about the importance of the survey for them as an outlet during the pandemic that we are actually going to start it up again just to continue to provide that outlet. I figure if it's helping some clinicians get through the day, it's worth it to continue, and we'll just figure it out. So you heard it here first. But the story of the measure. So for you guys, I don't really have to tell you that we have too many measures. You kind of know that. And we don't have any of our own, but the problem was about framing what measures are for me. So I was thinking about the purpose of measures and the idea that they are connected to self-definition, right? The way people measure us is usually their way of telling us what it is that we do that's valuable and in what way it's important. And it provides a way of them knowing us and us knowing their perception of us. So it is a form of communication that has a very specific purpose. So it is particularly threatening when those measures aren't actually aligned with how we see our purpose. So that became the thing I wanted to correct. Now, I take a little detour here because this is a guy who informed a lot of the work that I did on measures or do on measures. His name is Will Reeves. He is something of a tech guru. And although his real-time job was in the CIO office of the Federal Reserve Bank, which is in Virginia, Richmond, Virginia, he would come for free and help me figure out how to automate many of the things that we did in qualitative research on the organizational side to make it easier to do some of our analysis. And so this is Will working in my office when we are actually working on a set of interviews I'm going to tell you about. And he was helping me figure out a problem and waving hi to somebody on actually a screen. This is Will in December of 2016. And this is Will about 4 months later. In January of 2017, he woke up jaundiced And it turned out there's a lot of issues, but he had acute liver failure. And he was largely in the hospital from then until the day he died, April 9th, surrounded by his wonderful kids there and family. And I learned a whole lot about the difference between quality and performance as part of this experience. And it's sort of ironic to me that the guy who helped me really do stuff also through his hospital stay taught me a great deal about primary care and what we find most important. So I get back to him, but the interviews I was doing was part of a study that began with a request from the Robert Wood Johnson Foundation. They wanted me to find a set of exemplar practices, roughly 200. They wanted places that were high quality, clinically excellent, and able to sustain themselves in what is admittedly a hostile environment to primary care. So I did that. And what I found from that was really some amazing stories. I myself conducted more than 1,200 interviews by phone with the world of primary care and its leaders. So I really got a very thorough picture of primary care. And I found some practices that did extraordinary things, like one that actually offered a text clinic. So this was a practice that was located in Section 8 housing area. And the majority of its patient community earned less than 10 grand a year. And they realized that they didn't know anything about filing for taxes because it never really mattered. And so they realized they didn't know about earned income credits. And so they hired some high school students to fill out 1040 easy forms for their patients. And in this community where the average income was 10 grand a year, in that first year, they brought in $7 million in earned income credits for tax relief. I mean, that is an example actually of primary care, right? There was another one that was actually up closer to you all, that was in a factory-based or manufacturing town. And during the recession in 2008, or the collapse of the market in 2008, a lot of people stopped going into the practice. It was an FQHC, and even though it had a sliding scale, they didn't have any money. They stopped going in, and the practice decided it wasn't about money. It was about a relationship broken. And so they created what was called the More Than Money program, in which they had a nurse that was designated, and anybody in the community could call that nurse and let her know if they didn't have a GED and they were studying for one, if they were a new parent and they were taking new parenting classes, or if they were doing some volunteer work for a community organization. And for any one of those activities, they could earn $10 an hour towards their healthcare bill. And they had patients started to come in again. I was sort of floored by this, and I said, oh my God, no wonder they came in, of course, because you were giving the care and paying for it too. I'm just not sure how that worked. And I'll never forget what this guy said. It was 2014 then. He said, it turns out if you invest in the community, they invest in you. And so during the Great Recession, when everybody was seeking cash and yearning for it, this FQHC had the lowest debt that they'd had in 30 years because people were choosing to pay them, and people with commercial insurance were choosing to patronize them rather than other practices because of the support they were providing to the community. These were just two of the many wonderful examples I saw. And what was true of all of them, and what I shared with RWJ and their band of experts, was that none of them cared about measures. In fact, they all said, sure, yeah, we can give you those measures because you think they're important. But they don't tell us anything about how we care for our patients or whether the patients are perceiving any benefit. And so we do this other thing. And that really sent me thinking, because you talk about measures and people just cringe in primary care with good reason. They were so articulate about the lack of connect with their work and every day, the purpose and function of primary care. So I sought to try to fix that problem. The first part of that problem had to do with the words around accountability. And the accountability as it's been applied to primary care is not a good word. It's something like a four-letter word. And it's because it is usually about holding somebody accountable because we don't trust them. So we have them document all sorts of activities and things they do to prove that they've done something. And that is not a way to measure quality. It is creating a relationship not based on trust, but actually based on doubt. And it creates some perverse behaviors among clinicians sometimes, particularly as this is linked then to their income. It causes them to say, okay, if I'm going to be held accountable for that, then I'm going to limit the population that applies to. You can only hold me accountable to my patients. My patients will only be considered my patients if they've been in within the last year, or if they've been in within the last 2 years. And there's a way in which that focus on empanelment and active patients actually perversely limits our sense of responsibility. So primary care is actually about being responsible for the health of the community in which it's located. And the language around accountability has caused us to dramatically shrink that sense of responsibility. I want a primary care that feels responsible, that has measures that connect to purpose and professional fulfillment, such that I feel responsible as the steward of a group of people. And I'm interested and invested in their health, whether they come in regularly to the practice or not. So how do we go about looking at that language? Well, we talk about it in the NASM report that Jen mentioned. The first thing I think we have to do is realize what these terms really mean. And a measure is simply a unit or a number, 42. It requires a context to give it meaning. 42 by itself means nothing. If I tell you that it is the temperature in a surgery room, it means one thing. If I tell you it's the latitude on the globe, it means another. If I tell you it's someone's BMI, it means another. If you're from my generation, I could tell you it's the meaning of life and you would understand what I'm pointing to. Context is everything. Measures are meaningful without context. Quality is about a standard created through comparison. There is no objective quality out there that we identify. Quality is about a standard that we agree upon, and we agree upon it because it meets expectations, and it requires comparison so that we know that those expectations are reasonable. Is this something that most places could actually accomplish? Is it reasonable to ask them to? Performance is a little different. Performance is simply how well a task is accomplished, and we can say if it's done well or not. It connects to accountability because accountability looks at how well your actions or performance are aligned with those expectations, right? That's what we're really interested in. When we talk about measures feeding a conversation of accountability, what we really want to know is, are people taking actions that are aligned with professional expectations and the expectations of the people who seek help? That's what we want to know. So then I realized with that, we have to start all over with measures. We've really gone down the wrong way for this. It doesn't take much to tell. I mean, 80% of what happens in primary care happens outside of diagnosis. So the fact that most of our measures are based in diagnosis is kind of silly anyway. Primary care sees every condition. So the idea that we would measure it by adding up all the measures that are related to all those conditions is kind of a fool's errand. But it's got to be that we can measure it. So how do we go about doing it? I decided to do an open-ended survey of patients, of clinicians, and of the people who pay for the care, employers. And it was an open-ended survey, and it didn't use any of the language that we're used to. No patient-centered, no value-based, no value proposition, because I didn't want a rhetoric-informed response. I wanted people to just speak from the gut. So it was really about what's most important to those seeking care and those delivering it, and how do you know it's good, and how do you assess it when you see it? When we did that, we ended up with over 10,000 comments, and they came about half of them came from patients, about half of them came from clinicians, and then I had to be more purposeful with the the employers, because I needed to actually survey the people at an office or at an organization who purchase the health plans for the employees, right, to get at them. So that was a little more targeted. But we took all their answers and we analyzed them using a really ground up approach, not the knee-jerk ground up. Everybody, it's very popular to say, yes, we analyzed our comments using grounded theory. We actually did that. We took all the comments and we let them speak to us about what was most important. And it turns out that doctors and patients really agree. The most important things are about human connection, professionalism, and the integrated experience of receiving healthcare and thinking about your healthcare story. That was wonderful to see. We were able to analyze what they shared and identify 18 what we called quality indicator areas, 18 areas that they all agreed on. There were others along the side, but we wanted to start with that shared agreement. And then we held a conference. The conference was Starfield 3 Summit. You can see here the room of people. We actually locked people in a room for 2.5 days and had them work on this stuff with us. And the 18 quality indicator areas that we had, and I had organized them into 4 domains. I was very excited about that. And everybody in the room tore that idea apart. It was great. There aren't any separate domains. Primary care is actually more integrated than that. It was a good wake-up call. This conversation of 2.5 days that involved leaders in all of the disciplines, involved patients, involved policymakers. We even had a couple of actuaries in the room. It led to a narrowing of the 18 areas into 11. And it's not that the ones that got knocked off weren't important. This was about, it's an academic exercise to this point. We needed to make it pragmatic. How to make this really useful for everyday application. So we ended up with 11 items. There is a digital recorder on every table that you see there. And in addition to all the comments and all the notes, I analyzed all the audio recordings, and the 11 items that we developed came out of the language that people used when they were talking about this stuff. Then we had a measure. We had 1 item for each of the 11 areas because parsimony is key. We had a measure, now we had to test it. We really tested the heck out of this thing. And I knew we were doing something that was going to be weird. So if a statistician told me, which they did, that I need 110 people to take the instrument in order to validate it, I used 1,000 people because I wanted the face validity to be so strong that nobody could debate it because their gut was going to tell them there's something hinky going on. So I did that. We did cognitive interviews. You really only need to do about 10. We did about 50. We did the online testing with 1,000. I don't know how to do psychrometrics, so I hired somebody with a lifetime achievement award in the area. Felt like I could trust him. He was one of the team that did the APGAR score. It seemed like that turned out okay. So I had him do it. And he said he'd never seen anything as strong or unique as this in his 30 years. So he asked me if I could do it again. So I did. We did another 1,000. It came out exactly the same. He said, well, maybe it's different when you do it in person. It can't be that this is so strong that you have 11 items that actually all load onto a single domain. There aren't separate domains. It was statistically proving what we all know, that primary care is both broad in scope and internally coherent. So sure, you want to test it in person? Well, let's figure out a way to break it. We did it in person and with another 400. We picked a hospital setting, a private practice, an FQHC, a pediatric practice. We were really trying to kick the thing. It continued to hold. So now we knew that we had to do some more types of validity testing. We did a practice-based electronic testing. So the previous was asynchronous and online with an anonymous audience. We then tested it specifically connected to practices. We had another 1,200 patients we did that with. And we fielded it alongside with 2 validated measures. that were also patient-reported measures, and we found it equally had strong concurrent validity. We fielded alongside of the What Matters index created by John Wasson, that speaks both retrospectively and prospectively to cost and utilization. And we fielded it alongside the patient enablement instrument, which speaks to patients' ability to self-manage and understand what's going on with their health. We did tremendous amount of reliability testing. Can it be done over and over? Does it reliably produce the same results? Does it show differences between practices and clinicians? Is it feasible to use? Lots of testing. Here's what we found in some, and anybody who's out there who's a nerdy quant person, I'm happy to talk about it more. But generally speaking, most people I talk to don't really know what the quant side is anyway. So what I'll tell you is we did a factor analysis, and in factor analysis, you get a factor loading between 0 and 1, and at 0.4, you've got a good question. That's when you hit something that you know is okay. 0.6 is particularly strong, and 0.8 is exceptionally strong. 0.4 is the gold standard, and most of our stuff was above a 0.8. A couple of questions were in the high 0.6s. So this was, again, that strong picture that Steve was saying. Then there's the scale that we use. It's a 4-point scale, and you want to know if your scale's appropriate. And you know, with patient satisfaction scales, usually there's an asymptote-like curve, right, where everybody circles at the top end, and so everybody gets something above 90%. It's not particularly helpful. What we found with this instrument is that people used all parts of the scale. It was spread out, which meant that people were actually paying attention to the questions and answering them independent of each other. It was a really good sign. And then, of course, I told you about the concurrent validity. This measure has since been validated in 30 languages in 35 different country settings. And there are some active pilots going on in China, Japan, the Netherlands, some other places I'll talk about in a sec. But so this is the measure. The language is very clear. The questions are pretty simple. My practice makes it easy for me to get care. Over time, my practice helps me to stay healthy. These are easy to answer. You endorse them on a scale of definitely, mostly, somewhat, to not at all. And the language level is written at about 6th grade. I do get questions. My doctor considers all the factors that affect my health. What if they have a nurse practitioner? What if they have PA? Are they going to be confused by the doctor language? And what I usually say is, well, we got 10,000 patient comments and none of them said nurse practitioner or PA. They all said doctor. So I don't think they're going to be confused. We didn't find anybody who was confused. And actually, when we talked to nurse practitioners about their own care, they referred to doctors, their own nurse practitioners who took care of them. It's just it doesn't actually mean the same thing it used to mean. People know what they're saying when they refer to it. They know they're talking about their care provider. So since I know you're interested in what does this instrument look like when you're using it, I figured I would share a few of the common facts. One is this isn't CAPS. This is not a patient experience survey. This is about patient perceptions of care and quality of care. CAPS is really an instrument that's based on the consumer experience. It is very transactional by nature. The PC-PCM is based on a relationship. And so the questions are founded in a framework of relational knowing. Are payers interested? Yes, they are. There are many payers. I talked to a lot of them. There are 2 pilots going on right now that are solely created and funded by payers, one by Anthem and one by Blue Cross Blue Shield. Lots of people are paying attention. It is endorsed. The measure is sent once to every patient in a year. It's sent to them during the month of their birth. We don't send it in conjunction with an encounter because primary care is relational. It's not just about encounters. So we send it during the month of their birth and ask them to reflect on the last 12 months of experience with their practice. It can be done with paper or electronic. It does not seem to show a difference with any platform. If you are doing it at point of care at the time of care, it will have a positive skew, but again, we don't like to do it in that encounter-based way. The minimal sample that you need is 30 responses per clinician. That would hold at the practice level too. It's also endorsed for practice level use. Once you hit more than 5 clinicians, a base minimum of 150 is sufficient. The math is simple. You add them up and you divide by the number of people who answered it. I always get questions about exclusions. We don't exclude anybody, just like we don't exclude people from primary care. We don't exclude them from the measure. We can't include anybody who doesn't complete the measure. So people like to see that there's some kind of exclusion. So I put that up there. They also want to know about benchmarking. And I have to say to them, you know what, this is a new measure. It was just endorsed, like 6 months ago. So no, we don't have a national benchmark. But what I can tell you is that we have in our validation work fielded this now 6,000 times, and the average across the country of those 6,000 is about a 2.7, or what would translate as a performance score into 69%. When these are, a lot of these are asynchronous, they're not connected to specific practices. When you connect it to practices, that does move. We're more likely to see a 3.2 or an 80% as the benchmark then. But if you take on this measure, what I suggest is that as a first fielding, you want a baseline anyway. I would send it out as a bolus and get as many responses en masse as you can in that first. And then you can use that as your benchmark as you progress. I also get a lot of questions because this is endorsed for use in MIPS. I promote this as something that should be used in a positive way, not in a winners and losers zero-sum game. The idea is not to see who's at the medium and who are we going to penalize versus reward. The idea is to actually focus on the measure and not the score. What is the measure sharing with us about what's most important about care, and how well are we doing along those vectors that it identifies for us? So any of the vectors that you're not doing well on are areas for improvement, and looking at the measure as a whole and not individual questions on it is what helps us to look at population patterns. It's worth noting, because I care a whole lot about equity, it's worth noting that most people ask me how this works with minorities or how it works with low-income people. And my response is usually to challenge some of the conversation that happens around equity. We use the word equity now as almost a euphemism for poor Black family living in a crime-riddled area with only a mother and several children. It's an annoying sort of stereotype. That's not what equity is about. Equity is about understanding that everyone, regardless of their social or biological identity or condition, should have equitable access to care. We all have the right to the opportunity to achieve optimal health. And that means that it is useful and purposeful to look at our patient populations and consider whether our care is patterned by population in any kind of way. And that's not just race or ethnicity, though those are important ones for us to focus on. It's any kind of patterning that causes you to treat one population special and different from others that is a problem. So one of the examples I usually offer is that we have a common stereotype that people who are younger and in relatively good health could care less about relationships, love to go with convenience practices and quick anonymous care, and people who are older don't like to use technical tools and want lots of relationship. So what I did was say, okay, let's look at the 11 questions of the PCPCM, and let's look at all the people who've answered it for us who were between the ages of 18 and 29 and report that they're in good health versus those that are over 60 and report that they're in bad health. It's unfortunate that I chose two colors that look so much the same, and I apologize for that. But the light colored one is the young population. And what you see is, yes, they haven't been through as much together with their clinicians as we would expect. But what I'm really interested in is the part that comes at the end here. Because what it shows is that the younger folks are actually having more relational conversations with their doctors. They're talking more about their family, more about their community, and more about their health goals. When you're older and sick, our conversations are so driven by measures, and our reimbursement is so driven by measures that we are inclined to focus on chronic disease indicator areas, intermediate outcomes, to the exclusion of looking at relational connections and family and health goals. The irony here is that when you're older, one of the biggest problems is feelings of isolation and depression because of lack of social connectivity. And what we see is that that's the very time of life when we stop asking about that. So this is a good example outside of our usual ways of thinking about equity to say any patterned way that creates a patterned difference in the experience of care delivery, regardless of how you define the population, is a problem that should take our attention. So our current measures, they hold us accountable. It's a building and we can recognize it, but it's put together piecemeal over time and through precedent. It's not very pretty. I'm not sure I want to go there for my care. I want to go someplace more like this. This is Frank Lloyd Wright, right? This is Falling Water. This is designed to be organically connected to the place in which it sits. And that's the kind of primary care I want. It's more. It's about responsibility, not accountability. And the right kind of measures can actually promote that. So I get asked, is anybody using it? Yeah, there are a bunch of pilots going on. I'm happy to talk about them if anyone's curious. I wanted to come back to this story that I shared in the beginning of my friend Will and what I learned from it. This person on the left here is his primary care doc. This person on the right is his specialist, his liver doc. The two of them came to visit him when it was clear that he only had less than a day left. And what they found was me and his wife and his children and a few others in the room staring at the numbers on the monitor and really watching them as they were counting down and wondering about what this meant and how low can it go and what are we looking at. And what the primary care doc said was, stop looking at the numbers. The point now is for healing for Will, and that means paying attention to the person, not the numbers, and being here and fully present for him. And it was a wonderful sort of wake-up call. And I later wrote to the doctor in the hospital about the heroes who provided healing to this dying man, and that's really what they did. And it had nothing to do with our usual indicators, but it had everything to do with understanding the role of relationship and the sense of being known. I think that's what this measure is really about. So it was a big team of people that helped. It was a lot of people that provided funding along the way. I'm honored to present the work that really they all did and I just helped with, and I'm happy to answer any questions you might have.
Fantastic. Thank you, Becca.
You're very welcome.
Round of applause. As people contemplate their questions, I just wanted to just repeat some highlights from what you said. There's three key factors you said: connection, professionalism, and integration. And was integration of the context of the human?
For clinicians, it was integration in the system as well as the person. The patients really focused on their experience and that they felt very disjointed as they moved from place to place, and they liked having a place that made it feel like it wasn't quite so disjointed.
Awesome. I liked your definition of many definitions of primary care: organically connected to the place it lives. Beautiful. Primary care is improved outcomes and equity with cost stabilization. And you made a beautiful point in the NASM report of there's no better investment in healthcare to stabilize costs and to reduce costs, frankly. And then accountability is performance aligned with expectations. That was a good teaching point, I think, that we don't always think of it that way, that how do we align with expectations? And what are our expectations? Have we agreed that these are expectations that we want to work on together? All right, there were many more, but those are some of the highlights for me. And so we will open it up to discussion and dialogue and share ideas with our time here with Dr. Etz.
Well, you all know I can't stand the silence. So I'm just going to say thank you so much for this work. With Barbara Starfield gone, I think you are our new champion. And may your ideas
Thank you.
seed the world. I have a question. Has this what's the correlation with the thing that other folks important things, outcomes, mortality, hospitalization, costs, and so on and so forth? Where's the work on this measure with those things?
It's in progress. So we have a few places where they've been fielding the measure for a while. Actually, one of our best partners is the St. Michael's Health System in Toronto. They've been fielding the measure for about 3 years, and it's an integrated system there so that they can tell us a whole lot. They have a homegrown patient experience survey that they use that they're actually considering stopping because it's a lot longer, and this seems to give them an indication both, it serves as a sentinel both for patient experience and for outcomes, and they found that this measure is positively aligned with good outcomes and low cost and utilization. When we fielded it alongside of the What Matters Index that John Wasson has also validated to be both retrospectively and my favorite, prospectively aligned with cost and utilization, and actually a bit stronger than claims-based indices. This measure positively correlates with that as well. So we've got a lot of anecdotal and surrogate evidence, but this year we have a pilot with Anthem fielding in Colorado and Indiana, with Blue Cross Blue Shield fielding in Massachusetts. We have pilots starting with the state of Maryland and Virginia in July, as long as everything goes according to plan. So, probably means September, but those are done in conjunction with payers and with health systems. So we have all the claims data and all the quality measures data, and we'll be able to speak to that more fully then. We did in Virginia also target a 17 private practice pediatric system, because I get a lot of questions about, does this really apply to peds? So, if we're going to break it, let's break it. The point is to have something great for healthcare, not to say, hey, I have this wonderful publication. So we'll be testing it out. I suspect, Bruce, that we will have a lot more information like a year from now.
I wanted to bring up a comment that I'm grateful for you bringing forward in the presentation, and maybe this will help others who might be struggling with this. We, at MCW, we have practices who have started to use this, and we were about to use it, and then I paused because of the way in which we were about to use it, which was very similar to other patient satisfaction surveys and tied with the encounter. And it was really bothering me because it seemed like that was not what we were aiming for. And also because there were colleagues saying, well, gee, what are we going to do with this? Because we can't fix anything. We're not getting any data that will help us fix our wait times and our this and our that, and to try to help understand the purpose of it. So when you talk about a once a year kind of, in some ways, a very important data-driven gestalt of relationship and meaning and in the practice, that is very helpful to think about that. And then particularly when you couple it with your the graphics, comparing those two groups, so that you gave us a way to really look at, now how might we use this data in a meaningful way to look at patterns around our population and how we care for them. And so that's really helpful. So I thought I'd call that out because we may all be struggling with moving from the patient satisfaction benchmarks to using this in the manner that it's really intended. Thank you.
You're very welcome. I appreciate that comment. And I think it connects to that thing of the purpose and function of primary care. So if you talk to most primary care docs, they will not tell you that they live and breathe for really short wait times in the waiting room. You know, like they're really interested in the health of their patients. That's what they want to improve. And it's not that the wait time doesn't matter, but it's not like the most important mission-driven part of what we do. And so this actually connects to that. And I was on a call yesterday with CMS where they were asking me, well, are these things really actionable? And I asked them if any of them had seen the movie Shawshank Redemption, because I said, you've all been institutionalized. You've stopped being able to think. Let me ask you, and I pulled up the instrument again. My doctor knows my health goals. If I give you a low score on that, can you not figure out how that could be actionable or an activity you could do to improve that? Do I need to tell you, ask about my health goals? You know, like there's a certain way in which we have become really so programmed by this system that has been placed upon us that when we ask these questions, they don't seem silly when we ask them. They're coming from a defensive posture, right? Like, this is another thing that's going to be used to hammer me in ridiculous ways. So tell me what it is so I can be sure to meet that particular measure. It doesn't foster professional behavior, right? It's more like the TV Survivor show. It fosters meeting the target at all costs, no matter what. And that's not what we want. So thank you for that comment.
I'd like to build on that a little bit. Hi, I'm Edmund Ramley. I'm an implementation scientist on faculty in the department here at UW. And so I'm very concerned in my work with facilitating change, right? So you've pointed in the direction of how these components of the measure are so intuitive that we know what change needs to happen. And I'm wondering on a system level and on a practice level, whether you have any insight from the partners that you've worked with so far. What have they done to facilitate change? How has the measure been fed back to the people at different levels who can facilitate that change? Any insights that you can share about that?
Sure, no, that's a great question too. In the NASEM report, we talk about the context that measures are applied in, and we talk about it as an ecology, right? Like it really matters if you've created a healthy ecosystem or if you've created a more GMO-like, you know, situation, which is, I think, what we've done. The way that I usually talk about it is to say the purpose is to direct your attention to things that matter, and to signify for you to what you should aspire. And the fact that it seems to actually do that has caused a couple of things to happen. The first thing that I usually hear about is that it reduces burnout. And I should have guessed that. I feel a little silly saying I didn't, but I didn't expect that at all. And it's the first comment I usually get. And I think it's because it actually seems meaningful. It actually seems to connect to the everyday. The second thing that I hear is it actually does seem to change the nature of relationships that clinicians have with their patients. When this becomes something that is measured and cared about, they stop worrying so much about fee for documentation. And they start paying attention to, gosh, do I actually know the person in front of me, and do I actually know what their health goals are? And it changes the nature of that conversation. I've been told it makes it more frustrating when it comes time to documenting that visit, because EHRs are not set up to really support that well. But yeah, it really does change how people go about thinking about things. And I think I don't know if this is going to be bad for you or not, and I'm really sorry if I'm saying something bad, but one person said that I loved is it taught them that excellence is not actually the bar, that good is the bar. And when you have, it's the paradox of primary care that my friend Kurt wrote about, that on individual measures, primary care doesn't seem to do as well as other disciplines, but on the whole, we seem to have a healthier population. And it's because you always have multiple things going on with you. and achieving the highest score, making that benchmark a target, means that other things have to suffer. And that's why you usually get a range in those clinical guidelines. So we know where's the appropriate compromise, that we can make everything good enough. So on the whole, you're doing pretty well. Somebody on the CMS call brought up, well, when we started really pushing the clinical guideline for high blood pressure, and that became one that lots of people focused on, hospitalizations for hypertension were reduced by like 30%. Like, there's really good data on that. And I said, that's absolutely true. Did you know that during the same period, hospitalizations for hypotension went up 30%? That's part of what happens when you artificially focus on the wrong thing. You really have to look at the integrated whole. So I think that's some of what the measure does, and certainly the anecdotal evidence that we have so far supports that. With the pilots that we have going on in Maryland and Virginia in particular, I'll have a chance to do some interviews to pull that information out.
I'm going to throw something out there that is oversimplified, but if I was leading a health system and I only had to do one thing to improve quality for the clinicians and the teams as well as the patients, I would invest in ongoing therapeutic relationships with each other in the team and remove any barrier possible for access to our patients. Do you think that would be a oversimplified or a good strategy?
I don't think it's oversimplified at all. After the NASM report, one of the recommendations was to create an HHS Secretary's Council on Primary Care. That recommendation has been picked up by Secretary Becerra. There is an initiative to strengthen primary care under his office. Rear Admiral Levine is directly responsible for it. And they'll have their action plan ready in June. And so I get a lot of questions from them, and I get questions from other health systems about the same thing. CMS actually has an Office of Burden Reduction. I've talked to them a few times. It almost sounds a little Harry Potter, but it exists. And I've talked to them a few times, and they have the same question too. And a part of what I say to them right now is the number one thing you could do is simply recognize the work that your primary care workforce does. That prior to the pandemic, and this is really a thing, in 2019, hospitals, it is true, saw 283,000 cases of respiratory illness, and that is a big number. Primary care saw 185 million, literally saw 99.8% of all respiratory illness. And then we had a pandemic that is based in an illness that presents as respiratory, and we've had no attention for them. They have died at rates 5 times that of any other medical specialty from COVID. We didn't have any PPE. We didn't have a vaccine. We didn't stop going to work. We allowed our own health to be in jeopardy because our social contract with the population is patients first, their needs above our own. And lack of witnessing for that sacrifice is a huge hit to the morale of our workforce. I think that is actually the most important thing. If that were to happen, that in itself, the witnessing of the work that primary care has done for the past 2 years would do a lot to strengthen the therapeutic relationships that currently exist. We know this as doctor. I'm not a doctor, I'm an anthropologist. I just play one on TV, but we know this as doctors, right? That people come in and they talk to us, and just our witnessing of their suffering takes a little bit of that suffering away. We know this. Let's do it for the workforce. Then you want to figure out something that's immediate and actionable. I bet you have way too many of those measures that don't make sense. Just cut them in half. We've got good guidance for that. We have a core quality measures collaborative that is a combination of the American Health Insurance Plans, that's all the payers, CMS, the AAFP, and many other professional organizations. And yes, the current measures we have suck, but they have identified an essential set that's only 23 of them. Wouldn't it be great if we only had to report on 23 of them and not 87 or 105? And that would reduce the burden related to that by 75% right off the bat. Really easy to do, and you don't have to justify it. There's a national collaborative that's been working on this for 5 years. We're following their advice, and it's multi-stakeholder. It's another thing we can do. But then, yes, appropriate payment would be great. I would like people to stop talking about being reimbursed. I think doctors should be paid for their work, not reimbursed on the expense of providing it. It is a cost-based financial model that is particular and peculiar to the US. Most other health systems are based on an investment in the community, not based on understanding the cost of care and then adding a little bit on top. If you design a system around cost, it is perfectly designed to increase the cost. We know that investing in health keeps down cost and coincidentally turns out to be really good for patients, lower health burden too. So one thing that we can do is really pull away from fee-for-service driven models. I want to burn down fee-for-service with the rock. Yes, I'll say it, but we can't do that right away. So again, using the core quality measures collaborative set, the second thing we can do is limit our exposure to the vulnerability that fee-for-service causes. The fee-for-service system did not help hospitals during the pandemic or primary care. We need to realize that, right? So move more towards blended, move more towards value-based, and then we can long-term figure out how we can get off this fee-for-service chassis that has a tendency to break things down into pieces and violate that very integrative thing that everybody agrees is among the most important things they value in primary care. I'm sorry, I have absolutely no opinion about that. Yeah.
Please, Asma.
Hi, I'm Asmali. I'm a primary care fellow at the Department of Family Medicine. Thank you very much for this great presentation and for the work that you do and your team. So my question is, I'm wondering if there are any specific reasons why pharmacists were not included within the practicing clinicians.
That's a great question. Yeah, we actually did include pharmacists, but they were hard to find. So at VCU, I work with the pharmacy department because I love having pharmacists integrated into primary care settings. And Neil, I did some work with Neil Corson in Maine, and they have a wonderful system where the pharmacists work really well with patients on titrating medications and stuff. But it was hard for us to crack into that group and identify them. I ended up purposefully sampling 20 that I knew. When we had the people in that room, those 70 people in the room, we had 2 clinical pharmacists in there. But it is remarkably unrepresented in our sample. It is a huge weakness. I would love to be able to fix that. When we do the COVID-19 survey, we are actually partnered with a couple of clinical pharmacy organizations, but still we get like a 2% or less than 2% sample. I probably could have done more to figure out how to reach out more, but I'm always welcome to suggestions. And I would love to target practices that actually had pharmacists working in it. I think not only would there be something interesting to learn from those pharmacists, but I would bet those practices on the whole have patient experiences that are just better.
Yeah, thank you for explaining that, because I was wondering also, like, how could that be applied or adapted for pharmacies in general? So thank you.
Yeah, it's harder in pharmacies. It could be, but it's harder because pharmacies are based as businesses first, and they're very directed in their engagement with the patient population. They are usually about a medication need, and primary care is much broader than that. And so it's hard for it to apply to that specific setting, but the integration of pharmacy within primary care-based setting is a really helpful one. And looking at what that means and how to think of the clinicians in that setting as themselves having a relationship with patients who go in there would be hugely beneficial.
Well, thank you so much, Dr. Etz, for stimulating an educational conversation. When we go to our big system-wide meetings, we have a way of thinking differently and more effectively. So thanks for sharing your expertise. We're going to get back together with you here in a little bit, so we'll give you a little break, a little time to decompress.
I appreciate that. And I will put into the chat my email address. If anybody had a question with a little shy to ask it, or has any outreach or comments, have a low threshold. We love partnering with folks. Thank you for such a warm welcome.
Thank you for being with us. Thanks,
You bet.
everybody.